Hello, my name is Sungchul Park, and I'm a doctoral candidate in the Department of Health Services at the University of Washington and the Department of Healthcare Economics and Quality Management at Kyoto University. So it is my pleasure to present my dissertation paper that I'm working at the University of Washington. And so this is my dissertation work. So I have been involved in all stages from thinking of a research question to writing a manuscript. So I start with background and then explain a research question. But to answer my research question, I performed 4 different analyses. So I explain, so in the method and results section, I explain analysis by analysis and then summarize findings and discuss conclusion and policy implication. And the rest of the time is for Q&A. So Medicare is one of the U.S. public health insurance program, and Medicare provides health insurance coverage to elderly population in the states. So people who are older than 65 years. And in Medicare, there are 2 types of health plan: fee-for-service plans or Medicare Advantage plans. So FFS plans are paid for each service or each treatment, but MA plans are paid a fixed amount of money per person and per month. So this creates incentive for MA plans to avoid people who are spending more than their capitated payment. So I refer to these people as unprofitable people, and it is totally from the health plan's perspective. So to reduce risk selection, risk adjustment has been used. So risk adjustment means adjusting plan payment to accurately capture, reflect each individual's health condition. So if risk adjustment enables us to estimate each individual's expected expenditure as close to the actual expenditure, then ultimately I think it would reduce health plans' risk selection, and also it would induce health plans to compete based on providing high-valued care. So to more accurately capture each individual's health status, a new risk adjustment has been developed. And this is known as the CMS-HCC model. And the difference between the previous risk adjustment model and the CMS-HCC model is that the previous risk adjustment model only used inpatient claims data, but the CMS-HCC model is using inpatient as well as outpatient claims data, so that MA plans receive increased payment for sicker people. And the CMS-HCC model was initially phased in 2004 and fully implemented in 2007. So some papers show that the CMS-HCC model reduced the MA plan's risk selection. So they focused on people staying in FFS plans and then followed up their health plan choice next year. So whether they kept staying in FFS plan or switched to MA plans. And what they found is that in the post-ACC period, so after 2007, their differences in health status and healthcare use substantially decreased. As a result, enrollment into MA plans largely increased. But some papers argue that MA plans might change their risk selection strategy in response to the CMS-HCC model. And they found that it actually happened. So let me explain this figure first. So a risk score measures each individual's health status. So higher means worse health condition. And each dot indicates the amount of money that MA plans received as a capitated payment for each risk score group. And the bar indicates the range of expenditure for each risk score group. And this figure shows that the CMS-HCC model accurately estimates payment for low risk score people, but not for high risk score people, because as you can see close to that, but large variations, right? So this means that under the CMS-HCC model, MA plans would want to selectively enroll people, high risk score people, but whose expenditures are lower than their capitated payments. But Newhouse and his colleague re-examined the same research question, but they found that MA plans did not strategically behave in response to the CMS HCC model. They only looked at enrollment into MA plans, but they didn't look at disenrollment from MA plans. So it is still unknown whether MA plans selectively disenroll, like people who have higher expenditure than their capitated payments, especially among high risk score people. But I think this is likely to happen because previous studies show that compared to people staying in MA plans next year, people switching to FFS plans, they were more likely have lower health status, use more healthcare use, and incur higher costs. So in this study, I examined the MA plans risk selection behavior in response to the CMS HCC model. And to answer this question, I performed 4 different analyses. So first, I examined whether the CMS HCC model induced a strategic behavior. And I found that evidence, and I explained this strategic behavior through service level selection. So first, I analyzed the health plan's behavior, so whether MA plans actually increase copay for some services that are more used by unprofitable people than profitable people in the post-ACC period. And then I analyzed individuals' behavior in response to the health plans. So whether the service level selection, so the change in copays actually induced unprofitable people to switch out of MA plans voluntarily. And then if that is shown to be true, and I examined the reason for disenrollment from MA plans. And here, then what is service level selection? So the idea behind service level selection is that unprofitable people are more likely to use certain types of services than profitable people. So then health plans can avoid unprofitable people by making some services more expensive, especially if the services are more used by unprofitable people, right? And I think the health plans are likely to use service level selection more than other strategies because it is less costly. It means that health plans under the service level selection mechanism, health plans don't need to predict each individual's healthcare expenditure. What they need to do is predicting which services are more used by unprofitable people at the population level. So if health plans can figure out unprofitable services at the population level, then health plans can avoid unprofitable people without knowing additional individual level risk factors. And based on previous studies, home health care, ambulance, and psychiatric services are services that are unprofitable to health plans. So for the first, third, and fourth analysis, I used the Medicare current beneficiary survey between 2001 and 2009. So the MCBS data is longitudinal data, so I created 2 panels. So panel A includes people staying in FFS plans at ERT, and I followed up their next year's plan choice, so FFS or MA plans. And panel B includes people staying in MA plans at ERT, and then I followed up their next year's health plan choice. And I used 3 outcome variables, and each outcome variable is used for each analysis. So total Medicare expenditure for the first analysis, service-specific use is for third analysis, and the satisfaction of care is for the last analysis. And for the first one, so to examine whether the CMS HCC model induced a strategic behavior, I ran the difference and difference analysis, and separately for panel A and panel B. And the coefficients of interest are beta 1 and beta 2. So for example, for panel B, people staying in MA plans at year T, so the beta 1 tells the first year expenditure difference in the pre-ACC period between people staying in FFS plans next year and people switching to MA plan next year after adjusting for their health conditions. And the sum of beta 1 and beta 2 tells the first year expenditure difference in the post-ACC period. So for panel B, if the sum of beta 1 and beta 2 increase, this means that risk selection for panel A increase after adopting the CMS HCC model. And here is the result from the first analysis. So this is the value of beta 1, and this is value of the beta 2. So the beta 1 is minus $22,401, and the sum of beta 1 and beta 2 is about minus 84. This means that compared to people staying in FFS plans next year, people switching to MA plans next year spent $2,401 less in the baseline year, in the pre-ACC period. But in the post-HCC period, their first year expenditure difference decreased by $84. But for panel B, this is the value of beta 1. So in the pre-ACC period, compared to people switching to FFS plans next year, people staying in MA plans spent $1,418 less in the baseline year. But the sum of beta 1 and beta 2 increased by $4,996. So this means that their first line expenditure differences increased by about $5,000 in the post-ACC period. So this means that risk selection for panel A decreased, but risk selection for panel B increased as a result of the MA plan's strategic behavior in response to the CMS HCC model. Then for the second analysis, I used the plan benefit package data between 2001 and 2009. So I only include MA plans that had complete information on cost sharing. So I calculated the service-specific copays in the pre- and post-ACC period separately, but for 5 types of services, for example, inpatient care and home health care, health plans can set copays differently depending on a length of stay or a number of visits. So to make it comparable, I estimate these 5 types of services copay per a typical length of stay or a typical number of visits, and that is based on previous studies. And for other services, copay is per visit. And from the PBP data sets, I selected 31 types of services which are covered by MA plans as well as FFS plans. And this is the result from the second analysis. So each dot indicates each service, and gold indicates the pre-HCC period, and purple indicates the post-HCC period. And so y-axis indicates service-specific copays, and x-axis indicates service level selection index. So interpretation of the service, this has been developed by a previous study, but the interpretation of this is that services with higher service level selection index means unprofitable to health plans. So health plans would want to avoid people who are using these services. So services in this area. So compared to the pre-HCC period, the slope of the post-HCC period moves upwards, right? And this means that in the post-HCC period, MA plans actually increased. Co-pay more for services with higher service level selection index means more unprofitable services compared to services with lower service level selection index means less unprofitable services. And then to examine whether service level selection induced unprofitable people to switch out of MA plans voluntarily. I estimate average number of services per enrollees for two different populations, so people staying in MA plans next year and people switching to FFS plans next year. And then I calculated the ratios between them for each type of services and separately in the pre and post ACC periods. But until 2010, the federal government, the US government, didn't collect claims data for people staying in MA plans. So I used the service, so to estimate service-specific use for this population, I used the survey data that is part of the MCBS data. So but the survey data only collects 7 types of service information on 7 types of services, and the last service, the physician service, capture all types of services that are provided by a physician. So that is like aggregated values. And this is the result from the third analysis. So compared to the pre-ACC period, in the post-ACC period, the slope shows that it shows like an increasing trend with respect to the service level selection index, right? This means that compared to people using services with higher service level selection index in the pre-ACC period, people using services with higher service level selection index in the post-ACC period, they were more likely to disenroll from MA plans. And this is the evidence showing that there is a systematic pattern of disenrollment by service-specific use. And to examine the reason for disenrollment, I analyzed the relations between disenrollment and satisfaction on care cost, quality of care, and access to care. And I ran the similar difference and difference analysis that I explained previously. And I used 10 different satisfaction measures, but the outcome of interest is satisfaction on out-of-pocket costs, because in my study, service level selection means making some services more expensive. So this is the result from the fourth analysis. So this is the outcome. Outcome is the out-of-pocket costs. And this means that in the pre-ACC period, so compared to people switching to FFS plans next year, people staying in MA plans, they were more likely to less satisfied with out-of-pocket cost. But the sum of gamma 1, so here is gamma 1 and gamma 2, and so the sum of gamma 1 and gamma 2 is about 0.176, right? That means that in the post-HCC period, compared to people switching to FFS plans next year, people staying in MA plans, they were more likely to satisfy with out-of-pocket cost. In other words, so I think this result shows that MA enrollees were more likely to disenroll because of mainly out-of-pocket costs as a result of service level selection. And I couldn't see any significant results for other 9 satisfaction measures. So to summarize my findings, so in the post-HCC period, so risk selection did not disappear. So in my study, I found that MA plans changed their risk selection strategy. So specifically, MA plans engaged in service level selection by increasing co-pays, especially more for some services that are more used by unprofitable people. And this induced unprofitable people to switch out of MA plans next year's voluntarily. And finally, people who were dissatisfied with out-of-pocket costs, they were more likely to disenroll from MA plans. And I think this finding strengthened my hypothesis by supporting the idea that disenrollment was attributable to increased burdens on out-of-pocket costs. And this is the final slide, and this study shows the evidence of the unintended consequences of risk adjustment in the Medicare Advantage program. And this resulted in two adverse impacts. First, it reduced access to some types of services, and which may affect quality of care or quality of life later. And it also incurred additional costs to the federal government because MA plans could save costs by simply transferring unprofitable people to the FFS plans, which is directly operated by the federal government. And my study found that MA plans, the CMS HCC model reduced the MA plans risk selection, which is based on risk score, so based on health conditions. But the CMS HCC model is not perfect. So I found that MA plans engaged in risk selection beyond risk scores. So this study provides key policy implications in terms of how to develop a better risk adjustment model. And I think the better risk adjustment model should address this kind of service level selection issue. And I'd like to, and without support from my dissertation committee members, Dr. Basu, Dr. Ko, and Dr. Kali, this work must not have been done. And I'd like to, and thank you for inviting me to Kyoto and providing like generous funding source from the States to Japan. And it took about more than 10 hours. Thank you very much. And this paper has been published as like MBR working paper in the States. So if you want to see the paper, like more details about the paper, please visit my personal website or just Googling like MBR working paper and this number. Thank you.